Good morning and a very warm welcome to everyone. My name is Tunku Muzaffar Shah. I'm a consultant physician and geriatrician currently based in Selayang Hospital, one of the public hospitals in the Klang Valley. The theme of our breakout session this morning is falls and bone health. We have quite a varied list of speakers for you this morning. The first speaker is Dr. Elizabeth Chong. She is one of our colleagues based in Hospital Kuala Lumpur. Dr. Chong has morphed into the leading falls expert in the ministry. She successfully established the first inpatient falls service as well as the first ortho-geriatric service in Hospital Kuala Lumpur. She is also the chairperson for the falls intervention team and busy trains people for that purpose. She is also the leader for the falls prevention section of the Malaysian Patient Safety Goals of the Ministry of Health. She has kept herself very busy this year, contributing to the clinical practice guidelines for osteoporosis as well as the clinical practice guidelines for the hip fracture pathway. She is also the treasurer for the Fragility Fracture Network Malaysia. Dr. Chong will be talking to us about setting up a primary care falls service. Our next speaker is Dr. Hannah Seymour. She is a geriatrician based in Fiona Stanley Hospital. She is very passionate about ortho-geriatrics and works closely with the orthopedic colleagues in acute ortho-geriatrics. She is also the medical director of Fiona Stanley Hospital. She is the clinical lead for the 4-hour rule program for the Royal Perth Hospital. She is also the clinical lead for clinical commissioning for Fiona Stanley Hospital and is also the lead for falls and aged care for the Department of Health. On a wider scale, she is also part of the steering committee of the Australia-New Zealand Fracture Registry and is the president-elect of the Fragility Fracture Network. Dr. Seymour will be talking to us about improving care of fragility fractures in the Asia-Pacific region. And last but not least, we have Dr. Tan Kuo Jing. He's the toddler amongst us, and I'm referring to his youthfulness. And he's not a geriatrician. He is a consultant in the Medical Assessment Unit of the University Malaya Medical Centre. He is currently doing a doctorate looking at the systemic effects of osteoarthritis in the elderly. Dr. Tan will be talking to us about osteoarthritis diagnosis and prognostication. And before we begin, just a quick housekeeping note. I'd like to remind the audience to please come up with your questions and submit your questions in the chat box or utilizing the Q&A tab. I'm sure you'll have a very interesting morning, and without further ado, I'd like to welcome Dr. Elizabeth Chong to present her talk.
A very good morning, everyone. My name is Dr. Elizabeth Chong, a geriatrician from Hospital Kuala Lumpur, Malaysia. Thank you for joining the APGN Pocket Meeting. And the title of my talk today is Setting Up a Primary Care Falls Service. Before I start my lecture, I would like to give special thanks to Dr. Nagamai Thiagarajan, who is the team leader of the Primary Care Falls Service in KKKL, Dr. Baizuri Binti Basha, the head of Primary Care Falls Service in KKKL, and Dr. Rosmahani Ali, which is our liaison geriatrician from our Hospital Kuala Lumpur, and my dedicated falls team in Hospital Kuala Lumpur, as shown in the photo. This is the first primary care falls service clinic in KKKL, started in February 2021, and these are all the team members. As you see in the circular, that is Dr. Nagamai, her very self. Falls and the older person. Falls are a complex multifactorial phenomenon. Falls occur more often with advancing age. Approximately 30 to 40% of those above 65 who live in the community falls each year. Half of all these falls result in an injury, and 10% are pretty serious as well. And it was seen that injury rates increases with increased age. The National Health and Mobility Survey 2018 in Malaysia shows that 1 in 7 seniors in Malaysia above 60 have had a fall, and 72% have falls once, and 28% actually have falls for more than once. And about 16% has to be hospitalized due to the falls. If you look at the injury due to a fall, almost 20% sustain a severe form of injury after a fall, which is rather worrying. Internationally, it's shown that falls are the leading cause of fatal injuries. However, what we need to remember is falls is preventable. So we should really be doing something about it. According to American and the British Geriatric Society guidelines, it is recommended that all above 65-year-old should have a falls risk assessment annually. This should include a multifactorial falls risk assessment, and it should be performed on those who has reported recurrent falls, which is 2 or more, report difficulties with their gait and balance, and those who seek medical attention at the emergency department due to a fall. Why are falls important? Because it is a very costly affair. Each year, about 50 billion is spent in America on medical costs related to the non-fatal falls injury. In addition, in terms of fatal falls, it is as high as $754 million. What are the other consequences that we are worried about? We also look into post-fall syndromes, which is characterized by dependence, loss of autonomy of the elderly, depression, loss of confidence in ambulation, and most important, family members' anxiety about the potential for injury, and it will limit them from allowing the elderly to mobilize. It is shown in some studies as well that 40% of all nursing home admissions are related to falls. First of all, I would like to illustrate what we have as a fall service in Hospital Kuala Lumpur. So the fall service in Hospital Kuala Lumpur started about 12 years ago. We started off with inpatient falls, looking at patients who fall in the hospital. We set up outpatient daycare falls in 2012, and eventually in 2018, we looked into patients who fell in the community and sustaining a fragility fracture, as in the orthogeriatric service. However, when we look into the whole history of how we set up a fall service, there is one missing link, which is in the community. After seeing all these patients as inpatient, as outpatient, as in the orthogeriatric team, we have nowhere or no avenue to prevent patients from falling if they are at a high risk of fall. So as we look into the missing link, we thought, a problem is there and we should do something about it. So as this is a problem, every problem creates an opportunity. So we started off with our step 1, which is the beginning of deciding on a fall service in the primary care setting. So looking at the beginning, we looked into a few things. We had a problem, a statement that we need to correct, an interest in the party that we would like to be in partnership with, education probably to have a link with our partners, and how the setup actually occurs. So how did we start? Looking into the problem, it is obviously a service improvement initiative. First of all, we want to look at who should be referred to this clinic. So when we thought about it, we thought it would be those who has got falls and risk of falls in the community, those who has been diagnosed with osteoporosis in the primary care setup, discharged from home-based falls clinic care, but however need a little bit more help in the community, those who have sustained a fragility fracture, having had the operation and now needing a bit more help in the community. And it's shown by systematic analysis, multifactorial interventions were effective among the older people if they've had a history of fall or other falls risk factors. So what are the falls interventions that we are looking into? Evidence have demonstrated that falls prevention clinic can reduce falls, both injurious and non-injurious, and improve activities of daily living among the high-risk group. In 2012, there's a Cochrane systematic review that also showed that clinical assessment by a healthcare provider combined with individualized treatment of identified risk factors, a referral to the appropriate management, and continual follow-up reduced the rate of falls by 24%. Or sometimes we are trying to implement something that our patients might not accept. A study by Davis et al. Actually looked into patients' perspective. the false service actually is well received. It is shown by the patient's appreciation in the integrated approach to address their multiple problems applicable to their patient holistically, positive feelings towards the reliability of the clinic as a place where they can return to ask more questions and get help. And they also claim that they received information that was empowering and is useful in terms of knowing how their health problems might affect their mobility and future false risks. So all in all, if the team is ready to start a false service and the patient seems to be interested, we have to look at our partners. So this comes to the word interest, which is the stakeholder. The stakeholder in this case will be our community team, and we need a leader to be in this area. So we have actually found Dr. Nagamai, which is who you have seen. She's a dedicated family medicine specialist with special interest in geriatrics, and she herself has actually done further studies on geriatric medicine in primary care. So we have the interest of a leader, but we have to look at the organization as a whole. Is there buy-in from the stakeholder as a whole, because it's not just the leader alone, but the whole team? What is the organization's current and future goals on providing service for older people in their community? The problem is, if there is no elderly population in this community, or there's no goals or any plans for this group of population, the false service is not going to kick off. So when we look at it, we also look at what related programs or services are currently offered by this organization. This is also vitally important because patients who attend both these programs and services might be related to the false service, as in we can have cross-referral between the programs and services. After looking into that, we have to look into resources that could be required. So the most important equipment in a false clinic is obviously a blood pressure set, which is available in any clinic. But additionally, if there are other equipment which could be useful, which is not costly, could be rehabilitation equipment which are simple, good strength dynamometers, bioelectrical impedance analysis machines, radiology facilities for x-rays, and bone mineral density machines. We are very blessed, as in KKKL, which is where Dr. Nagamai works, all the equipment and resources are already in existence, and they are available to be used. Next, when we move on, we look into education as well. Dr. Nagamai has got special interest in falls, have actually looked into some of the falls that has been occurring in their primary care services. But however, in addition to that, we would like to give more theoretical education, not just to her, but to the whole team as well. So there was a series of workshops that we started running prior to the decision of starting a falls service. This is important because the team need to know what they would be embarking on and would they really be interested or able to run the service. And on top of that, when the clinic has already started, we have ongoing lectures as well on site. In addition to that, prior to the starting off of the falls service, they had some practical attachment to the hospital and our daycare to have a look at how a falls service is run in the hospital and the type of patients that could be referred to them, for example, after a fragility fracture. And also ongoing clinical training is occurred during our visit to the site. If you can see in the photo, that's Dr. Rosmahani herself conducting an ongoing clinical training and case discussion with the patients that I've met with that morning. We had a look at the effectiveness of the teaching style, both theory and practical, by doing a pre and post test for all the participants who attended the education session. Then we look at the staff role and who could be part of the falls clinic service. So in our hospital, we have got a physician together with a whole group of allied health, as you can see in this slide, to assist in our falls service in the hospital. And we would like to do the same in the primary care service. So when we go for more education sessions, we look into the role of team members. As you can see, this is our falls nurse, talking about how a falls history could be taken by a falls nurse. And we do some training on the assessment by each individual allied health by the falls team that you see early on, which is consisting of both the physiotherapists, occupational therapists, in addition to our nurse and our dietitian. In the education, we focus on the formulation of a diagnosis, the management of falls risk factors, osteoporosis management, and future rehabilitation needs. If you can see in this diagram, which is rather busy, these are some of the assessments that's conducted by each team member. So the physician will be looking into history, comorbids, and physical assessment. The nurse will be looking into orthostatic hypotension and probably assessing the connection. And for the pharmacist, they'll be looking into the drugs list and the drug interaction. the physiotherapists looking into balance assessment, aids needed, and rehabilitation program. And occupational therapists will do the functional environment assessment, and the dietitian looking into sarcopenia and nutrition. All these team members are actually very important in running a fall service, but however, if there is no availability of all this allied health, the most important component that you could start off with is probably the doctor, the nurse, and the physiotherapist to kick off your service. In terms of management, after learning how to assess the patient, we educate the team on prioritizing the intervention for modifiable risk factors, address falls injuries, look into the bone health, discuss the importance and strength and balance exercise, rehabilitation goals, and the collaboration with the patient and their caregivers. Okay, what are the interventions that's proven in studies to work in falls clinic or falls service? Single interventions with proven benefits, unfortunately, is only exercise programs looking into strength, gait and balance exercises such as physiotherapy or Tai Chi. So exercise trials have actually shown that it reduces falls, both of injurious and non-injurious falls. But however, it showed no association with mortality. The most commonly used management in falls services are multifactorial interventions. These multifactorial interventions is shown to modify any identified risk and is highly effective to reduce both falls and the risk of falling. So the attention to domains that we particularly look at are postural hypertension and cardiovascular diseases, balance transfer, strength and gait training, reduction in medications, particularly the falls risk increasing drugs, management of visual deficits, home assessments, and footwear. So multifactorial interventions have shown to reduce the rate of falls, but unfortunately the recent meta-analysis and systematic review has shown that it's made little or no difference to falls-related fractures, falls required hospital admission, medical attention related to health, morbidity and mortality outcomes. Once we've looked into all, we are ready to get it going. So we have to look at the setup. So the next thing we did was to visit the place that we thought that could be a place for the fall service, and we met with the team leader together with the organization leader, which is Dr. Baizuri. We had a site visit and we evaluate how the assessment could be done and have a look at the equipment and the area of rehabilitation. So after that, when we found a place, we decided that some best practices have to be set in so that the whole team would know how we should start and how do we progress. So there's regular updates for the medical team, and the falls in the community guidelines is in progress. Whilst for the public, we realized that apart from the team needing to know what falls is related to, we decided the patients should also be given education. So infographics and application to the patients were also in progress. And we also plan to have a Falls Prevention Awareness Day together with International Falls Day and their group therapy. With our blessing in this family medicine clinic, there are actually group therapies for patients with general good health, patients who need a little bit rehabilitation generally, and those with multiple morbidities. There's already different group therapies going on, and we decided that falls should have a group therapy as well. Because it is shown in this study of a randomized control trial, cognitive behavioral falls prevention program are actually very useful, as in this Stepping On program in Australia. It is shown that we could empower our patients to learn about falls, and together in the group therapy, they can encourage each other about the knowledge they have, and hence, the reduction of falls is seen among 31% in the intervention group. In the education for the patients, we look into individuals at risk of falling and their caregivers in learning about what measures they can take to prevent further falls, how they could stay motivated, how the physical and psychological benefits of modifying their falls risk, and where they can seek further advice if required, and how they could cope with a fall, and how to get help if they've fallen down and no one is around. After having set up all that, this is the beautiful Falls Clinic that started their first day of service in February 2021. That's the entrance of the clinic, which is very important. It is a big entrance for easy parking for the patients and very easy to find. Elderly patients find it very difficult if there's no parking and they could not be dropped at the site. So this is an ideal situation for them. If you can see how the multidisciplinary team is at work now, there are the nurses taking the history and assessing cognition, the pharmacists giving counseling, and the physiotherapists was doing an assessment on patient. And at the same time, you can see that we have on-site case discussion, and that's myself talking to the team with the patient about the case. Having set up the fall service, we need to know, what do we do? How do we move forward? It's extremely vital to know that we need to have project goals. So the sustainability of the service is extremely important. We have to continue with development and planning, and we have to look at the project effectiveness. And it will be good if there's some research going on to know how we progress and move on from there. In terms of sustainability, we have to look at the capacity to continue to engage the program to the participants and the stakeholders. This is very important, that we do not start a service and we ignore what is the receiving end going to say. So what we did is, we have goals is to prevent fall prevention service, we keep it alive, we sustain the service delivery, and we build upon the program that was started. When you start a service, we could not put it from A to Z. We started off with small so that we could see that we can build on it gradually with feedback that is provided by the participants and both the stakeholders. So we frequently have to redefine the scope of our activities. We need to use creative use of the resources that is available with minimal costs. And we look into partnership strategies. As the progress of the clinic is going on, we realize that we can let go more of the initiative that is started off by the primary care team themselves, because they know the community and patients more than we do. So now we are stepping backwards to provide as a guide and a discussion partner instead of one who is setting it up. So we heighten the demand for activities via education and outreach as well, and we select more acceptable and affordable activities with time. In terms of development and planning, we have to identify clear measurable objectives for the community or the region. It is different because as time goes by, the population in the community might change. So we have to look at the community that we are focusing on. First of all, probably we will look at patients who are at high risk of fall, to look into that first, or who have already sustained a fall. Then probably we'll move on to the population who is at risk of fall, that we want to prevent them from having even their first fall. And the others, well, we'll look at risk factors of fall. For example, a patient with diabetic, which is in a non-communicable disease clinic, might have extremely high risk factors for fall due to the retinopathy or neuropathy. We might focus on this group of patients instead. But obviously we start off with those who have already fallen, as the high risk of them falling again. So then we set on some interim benchmark to look at how the program is progressing and how the patients are managing in coming to the falls clinic and the progress. And we chart the progress over time, and we assess the plan regularly to determine if it is going the right direction. Later on, we have to look at the project effectiveness. With the monitoring going on, the team has actually designed a clerking sheet so that we can write down all the statistics and the particulars of the patient and look into the input from the patient and collecting the data from what we've been doing. So we have to evaluate and analyze what is going on, what is working and what is not working. It is something we do monthly to look into our patients and the effectiveness of the program. And also, we use it to revise as well. As in our clerking pro forma have changed a couple of times, because we realized if the incidence of time and the education level of the patients, some of the things is actually not applicable. So we have to change in time with the progress and evaluation that we have been going on. What about research? As we speak, Dr. Nagama and team herself is probably presenting at the MCGM on a poster of what has been happening in the falls clinic. So what can we do in research? So we look at process measures and outcome measures. So what would a process measure look at? So we look at how we describe the program which is operating, how effective is the recruitment strategies and the characteristics. This is very important, that we are not recruiting patients who are not appropriate to be sent to the falls clinic, hence a waste of time. We have to look at the adherence of the model. At times when we decide on a long planning on how to go about it with multidisciplinary team functioning, it could be something which is not feasible as in real life, because the time might be too long and the availability of the staff could be an issue. So we have to look at the adherence to the model and the attendance of the participants as well. If the patients are dropping from the falls clinic program, there must be some issue, and we have to look into that and to get feedback from the team and the patients themselves. What about outcome measures? We have to look at the program benefits for the patient. So frequently we'll have to ask the patient to see if that's important, and even giving them a questionnaire to answer if they feel that there's improvement in the patient's health status. We have objective assessment of functional ability, which is not in the scope of this talk, but there are many which is suggested in studies. Or we can look at rates of falls, both injurious and non-injurious, after the attendance to the falls clinic. To end, to make the whole program a success, what we should do is we should constantly illustrate that the program is benefiting to the older persons in the community. It is not a worrying matter if it's not. We just need to tweak the program a little bit and to look at the progress and re-monitor and re-plan. So we should try to produce facts and figures to demonstrate the positive outcomes. If there is really, share the result in publications and presentations. If there are negative outcomes, we should also look into it and make it better. Unfortunately, in Malaysia, we are in a very interesting situation that many of the international studies and suggestion it doesn't work in our population due to our uniqueness of it being a multiracial society and the education. Apart from that, we should make program improvements based on the documented program that we have, looking in both the strengths and weaknesses. But most important of all, what we realize in the falls service is teamwork. So as a team, we should always have a debrief after our falls clinic to look into it on how we could do better or how we could strengthen the whole team in the next clinic. Last but not least, I will thank you for your attention. But if you're concerned about how to start a clinic and you're quite stuck, there's a lot of materials in the internet for you to follow. The CDC guideline on Steady is actually a very good tool, and there are a lot of ways of learning from it, both from brochures to patients, to physicians, and even guidance on how to go step by step. With this, I will end. Thank you very much for your attention.
Hello, thank you so much for inviting me to give this talk. My name's Hannah Seymour. I'm a geriatrician from Fiona Stanley Hospital in Perth, Western Australia, where I work looking after people with hip fractures and other orthopaedic injuries. I'm also the president-elect of Fragility Fracture Network, which I'll talk about a bit during this talk. We're going to talk about how we can improve the care of fragility fractures in the Asia-Pacific region. So hip fractures are a common and painful condition. And so as geriatricians, we've recognised that we want to try and improve that care because we know that our older patients suffer when they come in with a fracture. I'm very lucky that the hospital that I work in is very well resourced, and we work in really beautiful facilities with a nurse specialist who works with me in partnership and helps collect a lot of this information. What's really important about the way we work is that, as you'll see from this picture, I work with a team of people. So we very much work in partnership with the orthopaedic surgeons and the anaesthetists, and every day we'll talk about the patients who've come into the hospital and what approach we're going to take with them. That's been absolutely imperative in improving the care of the patients that we look after. So how do we go about improving hip fracture care? So I think there's very good evidence that what you want to do to improve care is reduce variation, and overall that will improve the quality of the care that we provide. And then you want to move the care to the right, so you want to improve everybody's care over time. And that's what hip fracture has been improved across many countries in the world by taking this approach to reducing variation in care. That started with the UK National Hip Fracture Database, who published one of their first reports in 2011. And Colin Curry, who was the clinical lead at the time, came and talked to us in Western Australia about using that audit and standards approach to improve the care of the patients who came in with hip fractures in the UK. Again, hip fracture is common. it's serious and it's well defined. And in most Western countries, nearly everybody with a hip fracture comes to hospital. So it's very easy to identify and count, and care outcomes are costly, and therefore improving the quality and the cost of that care is attractive to both the system managers, the people who run your hospitals, as well as the clinicians involved. So what they did in the UK was the British Orthopaedic Association and the Geriatric Society got together and published something that was originally called the Blue Book. And from that, they then developed a set of data that they wanted to collect and show that over time they could improve care. And they've done that very nicely. So this was back in 2011, and at that stage, they showed they could reduce the 30-day mortality significantly. And they've got very impressive data from the UK showing that that trend has increased, and they've continued to reduce mortality of patients coming into hospitals with hip fracture. So in Western Australia, we're a relatively small state in terms of population, although very large in terms of area. And at the time, back in 2011, wanted to look at some of the care that we were providing across different hospitals. We thought about some possible KPIs, and were given a small amount of money and some premium payments to try and improve the care of this group of patients. And essentially what we did was very much copy the approach that had taken place in the UK, where they had a best practice tariff for fragility hip fractures. And the idea of that was to improve prompt surgery and appropriate involvement of geriatric medicine. And that in the UK had been shown to improve patient outcomes, increase the number of independent individuals after surgery, shorten length of stay, and overall provide more cost-effective care, which was very attractive to everybody. So what we wanted to know was, could we replicate that approach in Western Australia? So we did ruthlessly copy. That saved us an awful lot of time, because as anyone knows who's tried to set up a database, the first thing you have to do is define what to collect. And having a defined set of criteria from the UK allowed us to just tweak those a bit for the Australian setting and avoid about 2 years of work in defining a data set. So we just Australianized that UK data set and definitions, and we got a small amount of funding back in 2011 for a nurse in each site to collect that information, as well as improve the care for our patients, and a database in which to collect it. And so we started collecting data in April of 2012 in just 2 of our 3 big tertiary hospitals. And what we showed over time was that you could indeed improve care in exactly the same way in other countries. And we showed that by having this approach of collecting data, feeding it back to clinicians, we could increase the percentage of people who had surgery within 36 hours. Significantly over a 2-year period, such that by 2016, nearly 80% of our patients were having hip fracture surgery within 36 hours of presentation to an emergency department. At the same time, Australia and New Zealand had an interest in getting a hip fracture registry together, and using some of the work we'd done in Western Australia and work going on in other states, defined an Australia-New Zealand data set and started collecting data at more hospitals and publishing more and more reports each year with more and more patients involved, such that by 2018 there were 57 hospitals participating and 9,408 patients with a hip fracture included in the registry report. So how that works is that you have to define a guideline. So for us, that was performing surgery on the day of or the day after presentation to hospital with a hip fracture. Define the standard that you're going to measure. So that was really about being really specific about what you're going to measure and when. So every patient presenting to hospital with a hip fracture receives surgery within 48 hours if there's no clinical contraindication and the patient prefers surgery. The indicator is then the proportion of patients with a hip fracture receiving surgery within 48 hours of presentation, and the registry collects those variables by defining very clearly all of those required data fields. Importantly, one of the things we debated long and hard was, when does the clock start? And we decided that it started at the time and date of presentation to the first emergency department. And that's because in Australia, we transfer a lot of patients from one hospital to another to have this sort of surgery, and we should own our patients right from the beginning of their hospital journey. That's the sort of thing that would be very locally defined and driven, and would be the sort of thing that any registry starting up should define carefully from the beginning. I think the important thing about this timeline is to show how long this takes. So from starting to get together in November 2011, a group of interested clinicians from many states and New Zealand, it took a year to develop a formal steering group, another year to get funding from initially a foundation, then another 2 years to publish a guideline for hip fracture care, and a further 2 years to launch what we now call the Hip Fracture Clinical Care Standard, produced by our governing Safety and Quality Commission. And it was then that we launched our first patient level report. So that took quite a lot of time and required some funding to do that. So I think this is not the sort of thing that you expect to say that you want to start a registry and next year you'll have an annual report. It takes quite a long time to do that. These are the standards that we've defined to measure within Australia and New Zealand. They relate to different aspects of care. So the first one relates to care at presentation, and that really is about care in the emergency department and pain management. That's also reflected in Quality Statement 2. Quality Statement 3 is about an orthogeriatric model of care, which in Australia is generally provided by a geriatrician, but in some smaller sites, that model of care might be provided by a general physician or a GP. There's a quality statement about the timing of surgery, because that's felt to be very important in the Australian context to the care that's provided. And also a quality statement about mobilisation and weight bearing, as we know that there's some variation in the attitudes to weight bearing after surgery. And we were very keen that we follow the evidence and try and measure to ensure that most of our patients are weight bearing fully after an operation. Quality Statement 6 is about minimising the risk of another fracture. So that's about osteoporosis treatment and falls prevention. And Quality Statement 7 is about a transition from hospital care. And I think that's one of the quality measures that we do least well and is most complicated to measure. So in Australia and New Zealand, we've had reports published each year, and we started off with initially reports with numbered hospitals so that you couldn't identify each hospital. And each year we've made progress, and now only very, very small numbers of hospitals don't identify themselves. And this is the sort of report that we get with each hospital listed down the side and our progress over a number of years at the top. So what you'll see from this, for example, is that our average age is 82. The median age of men is 83, and in women, the median age is 84. People over 90 make up 25% of our hip fracture patients. And this very nicely allows us to compare hospitals at a very basic level with the sort of patients that they look after. We know that 37% of hip fracture patients had impaired cognition or known dementia at presentation in Australia and New Zealand. What we've been able to show through this approach, and as you can see at the top, is that the number of patients with, for example, a very simple procedure, such as a nerve block, on presentation to emergency, has increased substantially year on year. And this approach of targeting a particular area of care, making sure that we give people the information back and show that we can have exemplars. So I think that exemplar approach, where you can see that there's some hospitals where this is very possible, where it's very possible to get to more than 90% of patients with a nerve block, it then becomes possible. You can then use that information to help other places that are finding it harder to transform the care that they provide, and we can provide advice to each other about how we've improved care locally. Having local examples is really important. We've shown that you can reduce the average time to surgery over time, although this is much harder. But what we've seen is that hospitals with very long times to surgery have been able to use this information to talk to their managers about getting additional theatre lists, for example, to try and reduce the amount of time that people are waiting for surgery. But across Australia, patients who come straight to a hospital rather than being transferred have an average time to surgery of about 30 hours. We know that we've improved our assessment of delirium, and that's been something that we've really tried to educate people on and target over years. And we also monitor things like length of stay, which is really important to our services, but we also record where people go to. And in Australia, we have a very particular model of care with acute care provided generally in bigger hospitals, and rehabilitation provided generally by geriatricians or rehab physicians. And those episodes are measured separately. So again, it's important for us locally to record what percentage of people go to rehabilitation. We record how many people have bone protection when they come into hospital. As we all know, about half of patients with a hip fracture have probably had a fracture before in most studies. So the fact that less than 10% of patients are on bone protection medication of some sort before admission with a hip fracture reflects that our community is not adequately treating osteoporosis. And we improve that substantially on discharge, with a much larger proportion of people being discharged from hospital on osteoporosis treatment. But again, this could be improved, and there's substantial variation across Australia and New Zealand. We also now collect mortality rates and give those back to hospitals in funnel plots that helps compare mortality rates in different hospitals at 30 days and make sure that we're all providing adequate care. So we've done this in a very collaborative way, with hip festivals held across each state and multiple local groups getting together to present to each other on the areas that they've been focused on each year. And they've been hugely successful. With the advent of COVID, that's now become an online tool, and we've worked much harder on providing things like podcasts and short videos on our website, which are available to anyone who is interested. So just to end this bit of the talk, I think what we've found is that Australia and New Zealand have worked in partnership and they've made significant progress. Strategy's been crucial, so building on something that's been done elsewhere, but localizing it has been really important. And it's useful to be opportunistic. Sometimes don't things happen quite as you anticipated. And for us, naming of hospitals has been a game changer in trying to improve the care that we all provide. But importantly, it's a marathon, not a sprint, and it's taken us 10 years to really make significant progress and have most people with a hip fracture have their data entered into a registry, which is then used to improve their care. And it's also really important to think about how you package and sell that message to funders, because unless you get funding to set up some of these quality improvement processes, such as a registry, then you can't even get started. So that's where I guess Fragility Fracture Network come in. Our vision is a world where anybody who sustains a fragility fracture achieves optimal recovery of independent function and quality of life with no further fractures. And to do that, we want to optimise globally the multidisciplinary management of patients with a fragility fracture, including their secondary prevention. And what we want is to use the information that we've already gathered from a number of countries to learn and spread change more quickly than well-established services and countries. So it took us 10 years to improve the care in Australia and to collect good, accurate information to allow us to work out where we needed to continue to improve our care. But we want to think it's much better to adapt those strategies that have worked elsewhere. But we're very, very aware that applying them without localizing them won't work, because all the evidence about improving care is that you have to apply it to the local socio-political environment and use that shared expertise and learning, but adapt it to the local situation. So FFN is working on what we are calling the 4 pillars in the call to action. Pillar 1 is about acute care, Pillar 2 about rehabilitation, Pillar 3 about secondary prevention, and Pillar 4 about forming those alliances to allow you to implement those improvements in care across acute, rehabilitation and secondary prevention. Because without that, it's very difficult to make substantial changes that are required in care across your local country. And FFN really is about that working together to develop the education, communicate it, develop with national FFNs the local and international evidence to allow us to improve care in all regions of the world using this approach. So FFN's been trying really hard to develop resources for other countries. So Karen and Julie have edited a book on fragility fracture nursing, which may be really useful for nurses who are interested in trying to improve the care for their older patients in hospital. We've also, through Paolo Falasci and David Marsh, published a book on orthogeriatrics, which goes into some detail how to manage patients at every stage of their journey with a fragility fracture. Both of these, thanks to grants from various organisations, are available for free for download through the internet, and they're available off the FFN website. We've also recently developed a Fragility Fracture Network clinical toolkit, as well as a policy toolkit. And the idea of those is that they help other countries who are developing in this area to move much more quickly than the initial countries did to improve the care by stepping through what's required in both a clinical setting and a policy setting to improve care. They're also available on the FFN webpage under the call to action, and they're downloadable again for free and are available in a number of languages. Dave Marsh has spent a lot of time developing a guide to the formation of national fragility fracture networks. And again, that provides some guidance on how to set up a fragility fracture network, which is that multidisciplinary group that aims to work together to try and improve care locally in different countries. And I'm very aware that FFN Malaysia is growing in its influence and partnership. So the next area that we've been able to make some progress is through an alliance called the Asia Pacific Fragility Fracture Alliance. And that's an alliance that was funded initially by Amgen, whose aim is to deliver effective care and fewer fractures for people living in Asia Pacific. They have funded the development, in partnership with FFN, a hip fracture registry toolbox. And that's this collaboration that shows how we work together as different working groups and special interest groups to develop tangible toolbox, which should enable people to, again, get together and develop their own resources locally without spending quite as much time as we did. So I think it's really important for you to know that there are people involved in APFFA from Malaysia, and we've had great support across the Asia Pacific region from a number of people, as well as from international organisations like IOF. So this just lists, for example, JK, who I know you all know well. So what we have suggested within this toolbox is that you need those essential components of local clinical guidelines and standards and quality indicators as well as the registry, to start improving care. So from those clinical guidelines, you can derive the clinical standards, which gives you the quality indicators to measure, which are measured and reported by a registry. Now that sounds very daunting, but it's really important. Hip fracture is going to be increasingly common in many Asian countries as the number of older people presenting to hospitals with fractures increases. And we know that because of the rapidly aging society across Asia Pacific, that's going to occur most rapidly in this region. So what we wanted to do was set out that roadmap for change that allows each country to define what are the priorities and try and start improving that care before this large number of fractures hits all of your hospitals. So the 7 steps that we've identified to establishing a hip fracture registry are, first of all, engage clinical leaders and champions, and I know that you have many of those in Malaysia. Consolidate and broaden stakeholder buy-in, so really start to communicate that message to build the case for change. And then work out how to start. How do you plan and fund? And starting small might be really important. But allowing countries to adopt a minimum common data set that's been agreed internationally reduces the work that is required to set up that pilot registry, to start small, start with 1 or 2 or 3 hospitals, collect some data, learn from that process, and then grow from there, growing through the governance and ethics process locally, which are very different in different countries, to finally setting up a registry. And again, there's very different approaches in different countries to how data is reported and whether it's reported locally or publicly, and whether you start with hidden names, so numbers, for example, or you go, rather than going straight to what we call full and open, transparent reporting, where all of the information is available on the internet with hospitals named, so that you can really start to build that transparent approach with our patients. So the hip fracture toolbox is available on the APFA website. And again, there's other information on there that you might find useful and has been tailored to patients in the Asia Pacific region. So finally, I think it's really important that we build that alliance locally in the Asia Pacific region. So FFM Malaysia last year organised a regional expert meeting on the prevention and management of fragility fractures in partnership with the FFN Global support. So, thanks to that was a great meeting, and we identified some things locally that we needed to work on. This year, we have a global congress being held virtually from the 28th to the 30th of September, ensuring smooth transitions in fracture care and management. And that's available for all people to register for, and there will be an Asia Pacific pre-congress regional meeting as part of that meeting, which is being held on the afternoon and evening of Tuesday, the 28th of September. So I'd really encourage people to register for these meetings. The registration has been designed for people from different regions, understanding different prices related to different economies. So please do go to the website and do consider registering for this meeting, which will further your knowledge and information about how to improve care within the Asia Pacific region for patients with hip fractures and other fragility fractures. Thank you.
Hi, a very good morning. I'm Tan Go Jing from the University of Malaya and the Aging and Age-Associated Disorder Research Group. Today I'll be sharing with you about osteoarthritis diagnosis and prognostication. First and foremost, I would like to thank my supervisor, Professor Tan Mo Pin, for giving me this opportunity and, of course, teaching me everything I know about research and also about evidence-based medicine. Okay, so let's start now. I will be talking about the different diagnostic methods and evidence for their validity, evidence for the predictors of progression, evidence for agents that slow progression, and evidence for arthroplasty, and also then I'll give you my conclusion. Okay, so then first and foremost, what is osteoarthritis and why is it important? According to Sharma, in the latest New England Journal of Medicine review, osteoarthritis is a disease of the whole joint that represents failed repair of the joint damage resulting from stresses initiated by any of the joint or periarticular tissue abnormality. And it is estimated that 250 million people, or 3.64% of the world's population, is affected by it. Knee osteoarthritis has doubled in prevalence since the mid-20th century, from 8% to 16% in the United States. And this is most probably due to the difference in our lifestyle compared to 50 years ago. And in the Malaysian context, Sumaya Mat and colleagues have estimated that the crude and weighted prevalence of knee pain and self-reported knee OA is about 33.3% and 30.8% respectively. So osteoarthritis is something that affects a lot of people, and especially the elderly. So diagnosis, what do you mean? How do you know? Everyone can tell you, oh, maybe I might have OA, but how do we diagnose? And how do we say that someone has a diagnosis of osteoarthritis? So how is osteoarthritis diagnosed? We have the American College of Rheumatology criteria, okay, which was first developed by Altman and colleagues. This criteria was first published in 1987, revised in 1991. As you can see, it is a very, very old criteria. And it was developed using a very small group of only 130 osteoarthritis patients with a comparison of 107 patients. So altogether, there were only 237 patients. Imagine, I think an average day or week in University Malaya or even in Klang Hospital, there will be definitely more patients than that. So Altman, in his original paper, claimed that there was a sensitivity of 94% and a specificity of 88%. However, as we can see, when Kawasaki and colleagues did a validity study in the Asian population, they found it was much lower than reported. And the clinical ACR criteria showed no cross-validity among their two other ACR criteria sets because they have one criteria set for just plain clinical, one with blood investigation, and one with blood investigations and X-ray. So Bello and colleagues, in a study of 549 patients with a mean age of 53.6 years and a mean BMI of 27.1, which is roughly what we would see in our clinics, found that only 292 patients, or 60.8 patients, fulfilled the clinical ACR criteria for knee OA. However, at 1 year follow-up, okay, only 236 patients, or 49.2 patients, reported persisting knee complaints, and only 17.5% reported an increase of disability. So what this means is we have this big group of people, 60.8%, 292 people, that we say that they have knee OA, but very few of them, about 2/3 of them, reported a persistent pain. That means 1/3 of them the pain has disappeared, and further on, only like 17.5% actually reported any increased disability. So what they found was there is no association between fulfilling the clinical ACR criteria for knee OA at baseline with persistent knee pain and also this increased disability. So that means ACR criteria may say you have OA, but it doesn't mean that 1 year from now you will have any increased disability. It means that ACR criteria may not be such a suitable diagnosis of osteoarthritis. So if let's say ACR is not that good, what other options do we have? Well, we can have imaging. So for example, Kellgren-Lawrence classification, again, first devised in 1957 and consists of 4 grades. And the criticisms for Kellgren-Lawrence include insensitivity to change, inferior inter-observer and interclass correlation coefficients. That means one person to another will give you a different classification, and inconsistency in its original description by even the original authors. And so different descriptions have been found to have an impact on the classification, especially at the lower grade. So what Schiffer found in 2011 was there were actually many descriptions of Kellgren-Lawrence used by different groups, and at different grades, what was considered grade 1 by this group may be considered another grade by another group. So then there is again this what we said earlier, the inferior inter-observer correlation. So what other methods can we use? Okay, we can try self-reported physician-diagnosed osteoarthritis. So while ACR will require some X-ray and even blood investigation for research purposes, many patients only have self-reported physician-diagnosed osteoarthritis. That means they went and see a doctor, the doctor has seen them before, and the doctor says, "Auntie, you have osteoarthritis," and then they carry the diagnosis with them. So Tan and colleagues found that persistent knee pain, limited stiffness, reduced function, crepitus, restricted movement, and bony enlargement appear to be most useful in diagnosing this osteoarthritis. And they found that if you use these 6 criteria, up to 99% will have agreement with radiographic OA when all 6 features are present. That means if, let's say, patients have all 6, then when you do an X-ray, most of them will also show that they have osteoarthritis. Marsh and colleagues also found in a study of 106 patients when examined. So what they did was they take 106 patients, and then after that they will have a trained rheumatologist to examine them again. So 81%, when 81% say that they have definite OA will have confirmed OA. 57% of people will say they may have possible physician-diagnosed OA, have OA, and only one person who self-reported that he doesn't have OA, when the rheumatologist checked, he has a clinical OA. And Zokia and colleagues in their study of 224 Australian women found that self-reported physician-diagnosed OA was the best predictor of radiological OA with a specificity of 64%, a positive predictive value of 57%, and a negative predictive value of 71%. So self-reported physician-diagnosed OA is a pretty good, useful tool. However, given that the weakness of the ACR criteria and radiographic OA that we talked about yesterday, validating self-reported physician-diagnosed osteoarthritis by comparing it against maybe the ACR or radiographic criteria means it will perform no better than the ACR and radiographic OA, because you have a not so good diagnostic method and then you're comparing it against so even though you have like 80-90% correlation, but you're comparing it against a very not so good criteria. So agreement between self-reported arthritis and the reference standard was only moderate, and with sensitivity specificity between only 66.7% and 75.5%. So moving on, so what we data from PISA. PISA is the Promoting Independence in Seniors with Arthritis. This is a study that we are currently doing in University Malaya. So it's a longitudinal study of 225 individuals, and we collected demographic, physical, psychosocial characteristics, and we compared the differences between the 4 diagnostic criteria in NEOA. So we found that patients with a high depression score, as measured by the Hospital Anxiety and Depression Scale, is a significant predictor of patients with ACR criteria OA. And patients with the presence of knee pain, just having knee pain, is significantly predicted by a low KOO score. So we can tell that just by having different predictors, that there are differences in the population using the different diagnostic criteria. So if, let's say, that means to say that patients that you label them as ACR criteria OA are more likely to be a depressed group or have higher depression score. And patients who you label them OA on the basis of patients having knee pain, these are patients who usually have lower KOO scores, which means they may have lower symptoms of function, lower symptoms of ADL and all. So this tells you that maybe if you do studies using different diagnostic criteria, maybe they are not so comparable. So what other options do we have? MRI. So MRI has potential, but it's still plagued by a lack of standardization. So a research group will use a different method, another research group will use another different method, and then there's also the image post-processing, of course, also the expense and also the access. And also biomarkers. Studies have identified a plethora of molecules, but the evidence regarding their efficacy is limited, and the findings are often conflicting. And this is brought on by a lack of coordination, and no suitable biomarker has been identified. So what a lot of these studies do is they are just take a lot of bloods from a lot of patients, and then they see with OA, and then they see, all the OA patients is high in this marker, and then they go and write up a paper and publish it. So if you look through PubMed, they will have hundreds of biomarkers and they say, oh, this one is significant, that one is significant. But actually, if you look from one study to another, the one will say this will be high in OA, the other one, after the next paper, they'll say it's low in OA. So there are a lot of conflicting evidence. So and when we look at the diagnosis of OA, maybe it's time to have a paradigm shift. Maybe osteoarthritis is not so much one disease, because Devisa and colleagues, they did a systematic review of 24 studies. They found that sensitization to pain, severity based on X-ray, muscle strength, body index, and psychological stress suggests association with clinically distinct phenotypes, which means that all these patients, they may be, some patients we have OA, they have differences in sensitization to pain. Some patients with OA, they have severity based on different X-rays, and so basically it may be different phenotypes. That means, and then the Isola and colleagues hypothesized there may be 6 distinct phenotypes. So basically, osteoarthritis is not a single disease, but a manifestation or final pathway of many diseases. And why is this important? This one will, as I explain later when we talk about predictors and also agents that might affect the cause of osteoarthritis, then this one might come to mind. And I'm sure you all probably have a thought of reasons and also yourselves by now. Okay, prognostication. Who progresses, who responds to treatment, and who doesn't? And is everyone the same? Okay, so what are the predictors of progression? So there's actually no satisfactory predictor of progression. There's some studies that found association with high-fat diet, but this one is only in animal studies. There's nothing in humans yet. Terlink and colleagues, they examined and meta-analyzed 57 papers that examine 154 possible prognostic variables of progression. And only for clinical progression, okay, only having comorbidities has an association with clinical progression. And then for association for Sjogren-Lorentz at baseline, subchondral sclerosis, and femoral hip migration, and need are the only things that have association in needing a total hip replacement, which means the outcome is what predicts getting a total hip replacement, and patient Sjogren-Lorentz at baseline, subchondral having subchondral sclerosis, and femoral head migration. In other words, this is not predictive at all because patient already have severe diagnosis. It's like you see the X-ray, oh, patient have all these massive changes, so this is highly likely to be associated with total hip replacement. So nothing predicts it. Just having severe disease, of course, you're going to get the total hip replacement. Okay, and there's also some evidence that type 2 diabetes is associated with the development and presence of radiographic and symptomatic OA, even after the controlling for body mass index and weight, as noted above. But the meta-analysis has only 10 studies, and with so many patients diagnosed with diabetes in a population, you still can't say that, you still don't have a predictor of who will develop OA and who won't. And at the same time, the large variety of definitions of clinical knee OA makes it impossible to summarize the evidence to meta-analysis. So basically, when you try to meta-analyze, there's so much heterogeneity between each study. This study is looking at this criteria, that study is looking at this criteria, that actually most of the studies are not comparable. So Henriksen and colleagues in a meta-analysis of 5 prospective cohort found that the causation score of 0, showing that there is no causal link between knee joint loading during walking and structural progression of knee OA. And so that means some people say, oh, I always put my pressure on the left. So is that more likely to cause me knee OA on the left? No, not likely. And the evidence for occupational risk is again hampered by study heterogeneity and publication bias. So actually none of all these things, whether you talk about occupational risk, whether you're talking about joint loading, can predict knee OA. Okay, so Vixorit studied a French population cohort of 878 patients that showed that female sex, older age, high Sjogren-Lorentz grade, low physical activity, low psychosocial distress score, that means patient feels a lot of distress, and low vitality score were associated with more symptom trajectory. So sometimes we have to ask ourselves whether osteoarthritis is a separate disease or not itself, or sometimes we are better off managing the patient's depression than to treat the osteoarthritis. You treat the patient's loneliness, you may do more for the patient than than treating the osteoarthritis. For example, there was also some studies regarding physical therapy. There was very good evidence that physiotherapy works, but one criticism of those papers was whether it is a function of the physical therapy or a function of the physiotherapist's contact with the patient that caused this improvement. Because a lot of all these older patients, they suffer from loneliness, they do not have a social network, and so when they meet their therapist, they feel so happy. They get to see their therapist, therapists talk to them, their therapists work them up, and then, you know, the improvement is actually due to meeting the therapist and actually not the physical therapy itself. Yeah, so when they did studies regarding, you know, self-supervised, when they did at home, they actually do not see the same level of improvement as when they have physical interaction with the therapist. So how do we retard progression? Okay, we talked about how we diagnose, we've talked about, you know, what predicts it, and so far I'm very sorry, but I've given you all nothing but bad news that, you know, diagnosis is difficult. There's a lot of problems with diagnosis, and, you know, nothing really predicts it. You know, things that we thought were useful actually were not so useful. So maybe, you know, Gojing, give us some hope. Tell me whether there's anything that retards progress. Unfortunately, I have to tell you, no, not really. So there is actually no satisfactory methods to arrest progression. So vitamin D, not associated with reduction in prevalence, incidence, or progression of new radiographic OA and joint space narrowing. Okay, giving vitamin D won't help. Okay, so some Chinese studies show, oh, platelet-rich plasma in combination with hyaluronic acid is better than hyaluronic acid alone. But there's only 2 studies that showed that they analyzed only 2 studies in a meta-analysis. So actually, to be honest, the evidence is also not very good. Okay, evidence for bisphosphonate, again, the use of bisphosphonate for new OA, you know, to stabilize the joint. Okay, the studies analyzed include differences in duration, the differences in dose, route of administration, and, you know, they don't have the long-term data on the OA joint structure modification post-bisphosphonate therapy. So you can't say that, you know, giving bisphosphonate will arrest progression. Okay, Ferreira and colleagues, 2021, methotrexate, not effective. And saving the best for the last, you know, we have a lot of patients that swear by glucosamine, chondroitin sulfate and all, but, you know, that's statistically significant. So yes, that's statistically significant, but it's clinically questionable long-term benefits on structure and symptoms. And even when animal studies, you know, they talk about giving the glucosamine in animal studies, they are inconstant, heterogeneous, and of low quality. So, ladies and gentlemen, giving glucosamine and chondroitin sulfate actually does not help knee OA. But a lot of patients swear by it. And sometimes we have to question and we go back to the beginning where, you know, so much of the evidence say that, you know, it doesn't work. But why do some patients, they swear by it, they say it works so well? And, you know, it goes back to the earlier when I said that maybe it's not so much the joint itself, but maybe it's patients, you know, they are depressed, maybe they are sadder, they don't have a social network. No, they come and see the doctor gives them something, the doctor talks nicely to them, the doctor examines their knee, touch them a bit, tell them, auntie, it's all going to be okay. Maybe that is the best treatment and cure for a lot of our patients that come into you with knee pain. Okay, so this is a summary of what I have talked about, and as you can see, different groups. We have the Osteoarthritis Research Society International, you have the American College of Rheumatology, and you also have the American Academy of Orthopedic Surgeons. All of them treat osteoarthritis. All of them will have different recommendations, and the ones that are highlighted in yellow are the ones where the recommendations, they conflict with one another. And why do the recommendations conflict with one another? So a lot of times the recommendations conflict with one another because the studies that they use to come up with their recommendations are different. They diagnose osteoarthritis differently. The outcome that they measure is different from each other. So the implication is the optimal diagnostic criteria has yet to be discovered. And so sometimes when I don't want to be the bearer of bad news that actually there's nothing. It's basically what I've been telling you so far is nothing works, nothing is great, everything is more or less not useful. But And so it's just bad news, bad news, bad news. But I don't want the audience to come out of this thinking, oh, that everything is just bad news, bad news, bad news. What I want the audience to come out thinking is, look, because of difficulties in diagnosis and difficulties in measuring outcome and also progress, when someone presents to me in evidence, when someone tells me, this method works, that method works, okay, we have to be at the back of our mind that, sometimes maybe it's the differences in all these diagnosis, measures of progression and measures of outcome. So, and your patients swear by glucosamine, so maybe it's not so much the need that is the physical problem, maybe it's patients' depression, patients' lack of social network. So these are things that we have to keep at the back of our mind. So, moving on to the final section of my talk, which is about the evidence for joint replacement, because for a lot of orthopedic surgeons, they promoted that, patient has knee OA, go and do a TKR, solve all their problems for good. And if you look at the evidence, what they show is post-operatively, patients' symptoms improve in the short term. However, functional outcomes can be poor, and the lifespan of the prosthesis is limited. And up to 30% of patients are dissatisfied with their quality of life, which they deem insufficient post-operatively, which is a lot. And given that the risk that they've gone through and all the expenses, and you tell, 1/3 of us are actually not happy with the op. And one possible reason is the pain experience of people living with hip and knee OA was not adequately captured by existing measures. So, you don't really measure the pain post-op, the post-op pain, and after that, the weakness that comes from not moving, the deconditioning. And individuals have found to report that their outcome from TKA is good, despite the continued experience of pain and immobility, because they have gone through such a risk already. They feel bad to tell the doctor, hey, no, you know what, the op was more or less useless, And a systematic review of long-term safety found that the total knee arthroplasty group had a 4-fold increase in complications over a 12-month follow-up period. So dangerous and doesn't do very much. And again, Vizora and colleagues did a meta-analysis of 21 studies regarding the trajectory of disease progression in patients planned for operations. And they found that actually the studies had heterogeneous outcome. Again, different outcomes, different studies using different methods of measuring subgroup numbers and composition. And they revealed a stable trajectory over time, which suggests that OA is a chronic disease that does not inevitably worsen in terms of patient-reported symptoms. So that means a lot of them who have gone for op, they wouldn't, if they didn't go for the op, their symptoms would not have changed. They would have just remained the same. So, so what it means is people who have mild symptoms, maybe they shouldn't be pushing for an op, because, they will just continue to be mild for a long time. And given all the complications and all the persisting pain after the op, sometimes the risk-benefit does not make sense. And physical therapy post-operation is essential for patients to enjoy the full benefits of their surgery. However, studies show only supervised or remotely supervised therapy may be effective at reducing some of the impairment following TKA, but several studies without direct oversight produce poor results. This means that, if let's say after the op, then you don't care about the patient. You just, okay, uncle, you want to exercise, you want to exercise, I done your op already, you got no more, I discharge you from my clinic already. So if you don't supervise it, you're just going to get poor results, patient going to get paid, and it's might as well better that the patient don't do op. And again, you can also question, so is it because the supervised therapy really makes the patient better? Or, the regular contact with the physiotherapist, the doctor talking to the patient, holding their hands, stroking their auntie's hands and making auntie feel better, maybe that is a much better treatment for whatever she has, rather than just going straight for the op. Okay, and so my conclusion, the optimal diagnostic criteria has yet to be determined. The use of different criteria in different studies may limit comparisons between them, that there is some progress in devising methods for measuring function and symptoms to follow up patient and prognostication. Okay, but the methods for patient selection, who will benefit from all these treatments, remain elusive, and more research will be needed. So with that, I conclude my talk. Thank you very much.
Good morning, everyone. Wow. What a great start to our session this morning. I've learned a lot, and such a great number of speakers which show such variety. Yeah, and Dr. Tan, your message was a bit on the negative side, all about OA, but delivered with such enthusiasm. Yeah. So with being mindful, I'm going to tap into the enthusiasm right now. Okay, so you have, I'm going to veto and I'm going to put forward the first question. Since this is such an old disease, yeah, but yet we face it day in, day out, it's so debilitating and really impacts on people's quality of life. Yeah, are we having the wrong approach to this thing? Yeah, so I wanted to ask you what you thought about the social component or the psychosocial component about osteoarthritis. And I'm thinking it might be, you might have some faith in this, especially with all this talk about holding hands. So please.
Hello?
Dr. Tan, yes.
Can you hear me?
We can, yes, carry on.
All right. Sorry, can you just repeat the last part of the question again?
The last question is, I'm just wondering, since the disease has been around for so long, but yet there's much we don't know, and much of it is not concrete. I'm just wondering your thoughts about the psychosocial elements of osteoarthritis, which I think is relevant, particularly because you mentioned quite a few times that, you know, a possibly good approach is touching our patient's hand. So that would be quite a social element to me. So would you like to expand on that, please?
Okay, sure. So a lot of times we have to understand that we are treating the patient as a whole, not just we are not just treating the need, we are not just treating the disease. Osteoarthritis in bed 24. A lot of times, a lot of our geriatric patients, they are lonely. They have their children are far away working in another state, and so a lot of times, in my experience, when they come to me in the study clinic, they have 10 questions to ask, and a lot of time they are just looking for company, someone to answer their questions, someone to talk to them, and they leave the clinic with a smile on their face. I have not done anything for them. I didn't give them any meds. I've just talked to them, spent some time with them, and a lot of times I think before we subject 86-year-old lady to total knee replacement, before we subject them to anesthesia and all the risk of all the pain, and they need to be on opioids to control the pain, before we subject them to all those risks, we do have to consider, is there a psychosocial element to this? Are they lonely? Do they have, are they staying alone? Do they have someone that they can go exercise with? And if we jump straight to surgery, we jump straight to pharmacological management instead of starting off with the non-pharmacological management, I think, one, we do our patient disservice. Number two, we have put pressure, and our resources are limited, and we have put a person up for surgery, so we are drawing on our resources, limited resources. So I think a lot of times we have to be mindful. Yes, a clinic is sometimes, got 200 patients. There are a lot of patients that you have to go through, and sometimes, admittedly, we don't spend as much time with our patient as we should. But I think and not just, I don't think the responsibility also with doctors, I think also is with the community. If the community, for example, religious organizations, non-governmental organizations, if they have programs that will, bring older people together, get them to exercise, give them some social networking, give them social contact, I think that one will solve a large proportions of our issues.
Okay, thank you, Dr. Tan. I think, and you've touched on a very important point, actually. I think what you described ultimately is being a very good physician, yeah? Where you're listening to the patient, talking and providing comfort. So thank you. Okay, I have a question I have two questions which I shall rush through, but I just need to get this question out because I know Dr. Chang very well, and I know she's done a lot of work with falls in the hospital, and she's now branching out the tentacles into the community, and hence her talk. So Elizabeth, what have you found to be particularly challenging in your foray out into the community in trying to set up a fall service in primary care?
Thank you for the to be honest, we are the second wave geriatrician of Malaysia. We're actually a compassionate team who loves to work with the community. So before the fall service, in the primary care, we already started some dementia care services and linking with the primary care. So we kind of follow a similar model, but to get to know your primary care partners are not easy. So what we did, you look like this, wow, we just started a fall service. It's not that straightforward. It took me a whole year just to get to know them. To start off with, we have to do a lot of little webinars to the primary care team. So they come along, listen to the webinars, buy in a little bit, and the series worked well. We have a second one, and towards the end of the year, we even had a little mini conference for them, a little workshop. About 100 participants came by, and to just open their mind. To be honest, 60% of the patients in the primary care are actually elderly, and they have actually got their own KPIs on looking into falls apart from dementia care. So, but they do not know what to do with the data. They just collect it, they don't know what to do with it. So our role is just to say that actually you can do more than just collecting data. And we picked up a few who seem to be extremely interested, got their names, and some of them actually enroll in the primary care diploma program. So when they're in the program, they learn a bit more, and they show interest in falls, and they came and do attachments with us, and to show them how a falls clinic would help in our setup and definitely in their setup. So when we buy that, we continue to tell them we'll support you hand in hand. We'll come out to your clinic to help you guys like twice a month. They really love the idea, because to start up anything is really, really worrying and scary. We help them draw out a pathway, draw up a pro forma, and when we're out there, we discuss cases with them and basically continue education as well. So they like the idea, and when they saw what we have in the hospital and can do the exact thing in their primary care with a bit more knowledge, is fantastic. But what we notice is the patients who attend the primary care in terms of falls are so much healthier than the ones we see in the hospital. So I was expecting the same kind of population who will turn up, but in primary care, it is different story altogether. There are patients who've got good cognition, pre-morbids but well controlled. They walk into clinics by themselves with their strokes and neuropathy, high risk of fall, but they're very keen to be in group therapies and they would like to work. So these are actually the best population to target, because by the time they come to my falls clinic in the hospital, they have fractures, they can't walk, they are demented, they couldn't follow the program. So I think it's really worthwhile to invest in a primary care falls clinic.
Okay, thank you, Elizabeth. So you took a culturally sensitive approach here and found your co-conspirators to kick off. And I think you're doing a great job. Thank you. We have a question for Dr. Seymour, I think, since that inspirational talk of yours. Now, we've had a hip registry in Malaysia, but it was very short-lived. So clearly, there are many challenges in Malaysia, and I'm sure there are elsewhere. Would you have any advice for us on how do we convince our policymakers that this is the way forward? We all know as clinicians that data is a powerful thing, but that message hasn't gotten to everyone, particularly the policymakers. What advice would you give to us on trying to set up a registry?
So look, it's a really good question, and it is about being pragmatic and localized, I think. So I think the other question was about how do you get other people to, other specialties to recognize the importance of fragility fractures, and that's probably the starting point. So I think you constantly have to locally talk about what you're doing within your own organization. So we, for example, go and give talks to ICU because our integrated orthogeriatric service looks after really, really complicated people and keeps them out of ICU. But occasionally we ask them to see someone. And if they don't understand all of the people that you're keeping out of the intensive care unit, then they don't react really well when you ask them to look after a very small number of patients. So what we found locally is even when you have a really well-functioning service, you have to constantly remind people in your own organization of what you're doing, because if you're doing it well, it actually means that they don't hear about what's going on a day-to-day basis. And I think that's really important even when you're starting, because if you go and do case presentations in grand rounds and explain the level of complexity of some of the patients coming in, cared for by orthopedic surgeons. And I think unless your orthopedic surgeons are different to ours, You know, they're very good at doing what we ask them to do and what they're trained to do. They're fixing bones. But asking orthopedic surgeons to care for the most medically complex patients in our hospitals is probably not realistic and not using their skills to the best of that we can. So we need to work in partnership. And if we start explaining to our colleagues regularly about the patients that come in under them and the services that could help them, then it actually reduces everyone else's work in the hospital. And you have to get that local support to increase the services within your own hospital while you're doing the work nationally. So I think it is really important to keep enthusiasm up. It is a long journey. I started this in Western Australia with some colleagues back in 2003. So this is definitely a marathon, not a sprint. There will be ups and downs in any journey, locally and nationally. And at any point in time, hopefully someone within the leadership group is having a good experience and making some progress and keeps everybody else enthused. And then when they're having a downtime, someone else is having an uptime. So I think that is really important in any of these journeys. In terms of how do you start? Look, again, you know, at the moment you're in the middle of COVID. There's lots of challenges nationally. And you have to remember that most leadership teams in hospitals have multiple people coming to see them every week saying what is the most important thing for that person and that specialty. And so it is a bit about waiting for the right time. And what you have to have at that point in time is some information that allows you to make your case. So when you look at what has happened in most countries where they now have a successful registry, what started that was often a local Excel spreadsheet in a local hospital. And it isn't about a sophisticated registry at the beginning. It's about 3 or 4 hospitals getting together and trying to share their data locally, show how they can improve things, and making it, you know, realistic to begin with is really important. And that's where what FFN is trying to do should help, because what we're trying to say is don't collect lots and lots of information. As soon as you get clinicians in a room, we all want to collect everything that we're interested in. And what that does is make it impossible right from the start. And what we're trying to do is work together to say, just collect these 10 things. If you collect these 10 bits of information about every hip fracture patient to begin with, you will show a difference. You'll start changing your care. And then when you go to meet your politicians or your hospital leaders to advocate for a more widespread registry, you've got that history. You've got that ability to say, well, look, we did collect this. We've collected this in these hospitals and we've shown that this made a difference. And that allows you to then start talking about the very specific problems in the challenges in your setting. So for example, I've learned heaps by doing some of the talks I've given in different parts of the world about how different our systems are. So the idea that you can just take a model that works in one country and apply it completely in another is completely naive. The problems, the things that cause delays in different countries relate to the very specific funding mechanisms in your countries, the different pressures. So we always talk about bed pressures. Anything that reduces length of stay in an Australian setting is useful because we're always under bed pressure. That, I think, is less of a push for you. But for example, a lot of the delays in some countries relate to the funding of the prosthesis, which is not even thought about in Australia, where the prosthesis is the least of our problems and is included within the public system. So I think it is really about understanding your own system. And if you've got just a little bit of information over a short period of time, you can very quickly work out where the pressures are and where you can make rapid improvements. And then the other thing that's really important, there was a question about who should start this. So, you know, in Australia and in a lot of Western countries, consumer involvement has been critical. So it is that attitude that the getting consumers on board, getting older people on board, and using them to advocate to the politicians about how important this is, recognizing dignity of older people, not leaving older people in pain because of a hip fracture has been really important. But it's also about working out where your levers are locally within Malaysia, who has the most influence, who has the influence with politicians. And I think it has to be a partnership. So it has to be orthopedic surgeons saying, look, we've got a problem. We can't manage these patients. Asking us to manage complex, frail older people is not going to work. But you have to have the solution, which is often the geriatricians or nursing, multidisciplinary teams. Anaesthetists are a key part of this, to say, well, look, but we know the solution. This is the solution. Let's work together to try and help improve things. But you have to keep enthusiasm up. And that's where meetings are really important. I'm really missing going and seeing people face to face, because that's where you gain enthusiasm, when you go away and you actually have a chance to meet people and you go, oh, really? Is that your problem? Oh, that's not our problem. What are you doing about it? That's really interesting. How can we help? And I think when the world reopens, that will be really positive. And we hope that we can then get together again and start sharing those things. And in the meantime, we just have to keep hanging in there and keep collecting little bits of information and staying enthusiastic and waiting for the right moment and building on the information we need for that moment when it is the right time.
Correct. I agree with you. This meetings, then you appreciate it once it's gone, more or less, yeah. To be able to take some time off work, forced time off work, to reset and to re-enthuse ourselves. Quite a few questions have come in. We won't get to go through all, but Dr. Seymour, while you're there, a question is: Australia has obviously a lot of space. Yeah, you have a huge urban and rural area to cover. How do you square that? How do you make your services accessible? Is it just by sending a lot of people out, or do you utilize a lot of technology, or you travel a lot?
So a bit of both. So with hip fractures, that's very centralized care. So we actually provide most of that in Perth, and people have to fly down, and we have a Royal Flying Doctor service to help with that. That's one of the areas where I learned. I advocated really hard at the beginning when we were talking about the national registry, that we should only measure care from the time that someone arrived in our operative hospital. So in my hospital, if you like, and was shouted down and told, no, we need to measure from the time that someone arrives in their first emergency department. And actually, that was the right thing to do. That was hugely positive, because what that has driven us to do is to consider our patients' care from the moment they arrive in another hospital and make sure that we have ways to get them to us as quickly as we can, and we're not the barrier. So I'm sure you have the same pressures as we do. We're constantly telling people not to come, wait till tomorrow, it'll be better tomorrow, we'll have a bed for you then. By measuring from the start, we've made it our business to work with our FDS, work with our bed managers, work with our executive to say, no, that person's ours, even though they're not in our AD, they belong to us, we're responsible for their care. So that's one thing where I think, thinking about your sites, even if they're not in your hospital, is really important. In terms of community services, yes, I think we're trying to be better and better at virtual healthcare. It is always challenging. A lot of it still relies on phone, but I think in the next 5 years, we'll really make progress in virtual healthcare as a way of improving care in local communities outside of Perth. But I think there's balance to that too. I'm sure that in Malaysia, I know that you had some really remote communities. And what I've learned from going to those communities is probably not about the care that I provide on that day. You go to communities and you understand the context of that patient. As Dr. Tan was saying, you understand what you're trying to achieve in a very different situation with a very different social support system. And so I think it is still beneficial to go to some of these places at least once or twice to understand then what you're trying to help in dealing with people in very remote places. And that's really important in Indigenous communities and people with different backgrounds and diverse cultures, which I know is also something you work with in Malaysia.
Okay, thank you. Thank you for that. Right, we've got just a couple of minutes left. I have a question for Dr. Tan. What would your view be on the role of traditional Chinese medicine, traditional and complementary medicine, I should say, in managing osteoarthritis? Because lots of our huge sections of our population are huge believers. They seem to have less faith in modern Western medicine and quite a bit more into this. But why not? It's been around for such a long time. Your views, please.
Okay, to be honest, a lot of all these traditional practitioners of traditional medicines, they actually have a lot of patient contact. They touch their patients. They have rituals associated with healing. So in the eyes of a lot of these patients, they are doing something for me. Whereas the doctor will say, hi, uncle, how are you? How's your pain? Okay, here's a prescription. Next patient, please. So they don't feel treated in the sense. We have modern medicine. Our medicine has evidence, but they don't feel treated. Whereas the traditional practitioner will touch, talk to them, spend a few, 1 hour of rituals on these patients, and maybe it's the placebo effect. So in my view, as long as it does not involve taking steroids, because of a lot of these traditional practitioners contaminate their drugs with steroids, as long as there's no steroids involved, I think if they go for, and it's sterilized, if they go for cupping and acupuncture, why not? The evidence again for acupuncture is actually very limited, but why not? If it makes the patient feel better, there's a placebo effect, why not?
Okay. We have 2 minutes left. I'm going to rush through one more question, open to the floor. Does joint replacement reduce the inflammatory response associated with the OA joint? Obviously, it's more direct to Dr. Tan.
I'll just put in a quick one. I think the OA knee is a manifestation of the pro-inflammatory state. So if the patient is overweight, it's pro-inflammatory. Patient is diabetic, it's pro-inflammatory. Patient takes a lot of unhealthy food, sugary food, it's pro-inflammatory. So it's a manifestation. So you change the knee, but you do not change the patient's diet, lifestyle. They do not exercise. They still maintain the same bad habits as before. Then I do not think so.
Okay. Okay, do we have time for one more question? We might do another quick one. What is the prognostic outcome for disc replacement for cervical prolapse intervertebral disc for cervical spondylosis? Dr. Tan again, I presume. So the prognostic outcome for disc replacement for a prolapse cervical intervertebral disc. Would you know?
Unfortunately, I have to be honest with you. I'm just concentrating totally on the knee and osteoarthritis. So if PID and all that, to be honest with you, that's out of my head.
That's a fair, honest answer. Okay, I think with that, thank you very much to all our speakers, Dr. Elizabeth Chong, Dr. Seymour, and Dr. Tan. Thank you for your time. Thank you for your work. Thank you for your enthusiasm. And if there's nothing else, I think we shall end this session this morning. And good morning to everyone, and I hope you enjoy the rest of the conference. Thank you very much, and bye-bye.